Your patient's heart rate is crashing, 38 beats a minute, and slowing. The blood pressure reads 76/40. He is confused, his skin is cool and damp, and he is slipping. The heart is beating too slowly to keep him alive, and you have seconds to turn it around. There is one drug you reach for first. What is it? Here is your question. An adult client has a heart rate of 38, a blood pressure of 76/40, and is confused, cool, and diaphoretic, a symptomatic bradycardia. Which action is the priority? A. Administer atropine. B. Begin transcutaneous pacing. C. Start a dopamine or epinephrine infusion. D. Give a 500 milliliter IV fluid bolus. Pause and commit. 3, 2, 1. The answer is A. Atropine, first. In a symptomatic, unstable bradycardia, atropine is the first-line drug, and for good reason. It works fast, it needs no sedation, and it often lifts the rate enough to restore perfusion while you set up everything else. Pacing is powerful, and it is coming, but atropine is the move you make in the first seconds. Give it, and get the pads ready. Here is what is happening. The heart's own pacemaker, or the wiring that carries its signal, has slowed or stalled. Fewer impulses reach the ventricles, so the rate falls to 30 to 40, far too slow, and cardiac output is rate times stroke volume, so when the rate collapses, the output collapses with it. The brain and the heart stop getting the blood they need. That is why he is confused and hypotensive. Left alone, this slides toward a systole. Now, whether atropine will even work depends on where the block sits. If the slowing is up high, at the AV node, a sinus or junctional bradycardia, atropine usually speeds it up nicely. But if the block is lower, below the node, a Mobitz 2 or a complete, third-degree block, atropine often does nothing, because the problem is beyond its reach. So you try it, but for a high-grade block, you do not lean on it. You get to pacing, fast. So here is the ladder. First, atropine, 1 mg, given intravenously, repeated every 3 to 5 minutes, up to 3 mg total. Second, if atropine fails, or if it is a high-grade block, transcutaneous pacing, with sedation, because pacing hurts. Third, if you still need support, a dopamine or an epinephrine infusion while you treat the underlying cause and arrange a more definitive pacemaker. Atropine leads, pacing backs it up. Here is the rule to carry out of this. An unstable symptomatic bradycardia gets atropine first because it is fast and it often works, but move straight to pacing if atropine fails or if the rhythm is a Mobitz 2 or a third-degree block where atropine usually will not help. Drug first, pads ready. So when do you treat a slow heart at all? Only when it is symptomatic, when the slow rate is actually starving the body. Look for 5 things: a low blood pressure, a suddenly altered mental status, signs of shock, ischemic chest pain, and acute heart failure. Any of those, with a slow rate, and you act. But a slow rate in someone who is alert, comfortable, and perfusing well, that patient you monitor while you look for the cause. Treat the patient, not the number. 2 moves. Working together. Atropine is the fast first try. No sedation. Straight into the vein, and when the block is high in the conduction system, it can lift the rate in a minute. But atropine cannot reach a block below the AV node, and it has a ceiling. Transcutaneous pacing does not care where the block sits, it drives the rate directly, from the outside. But it is painful, so you sedate an awake patient before you pace. One is quick, the other is certain. Now 2 instincts that go wrong. First, leaning on atropine in a high-grade block, in a Mobitz 2 or a complete heart block. Atropine usually fails, and every repeated dose is time the patient does not have. Get to pacing. Worse, atropine can speed the atria while the block holds and paradoxically slow the ventricles further. Second, treating the number instead of the patient. A slow rate in someone well perfused and comfortable does not need atropine or pacing. It needs monitoring and a search for the cause. 2. To lock in. When is a slow heart an emergency? When the patient is sick. Signs of shock. I. Ischemic chest pain. C. Confusion, an altered mental status. K. A killing of the blood pressure. Hypotension. Any of those, you treat. And the latter itself. Atropine, then pace, then press. Atropine, 1 mg, up to 3. Transcutaneous pacing, if it fails. And pressors, dopamine, or epinephrine, if you still need them. But for a high-grade block, you jump to pacing. Now the wrong answers. B. Transcutaneous pacing. It always captures, so it is tempting to jump straight to it. But atropine is first line, it is faster, and it needs no sedation. You pace when atropine fails or the block is high-grade. Right, rescue, wrong step. C. A dopamine or epinephrine infusion. These are second line, for when atropine has not worked, and they take time to titrate. And D. A fluid bolus. The hypotension here is coming from the rate, not from low volume. No amount of fluid fixes a heart beating this slowly. Tie it together. Your cues: a heart rate of 38, a blood pressure of 76/40, a patient confused, cool and clammy, a symptomatic bradycardia. Your action: atropine first, then transcutaneous pacing if atropine fails or the block is high grade, with a dopamine or epinephrine infusion in reserve, treating the cause and sedating before you pace. And the outcomes you want? The rate and the perfusion restored, pacing ready as your backup, the cause corrected, and a bridge to a definitive pacemaker if needed. Now test yourself. Same slow rate, same low pressure, but now the monitor shows it clearly, a complete third-degree heart block, the atria and the ventricles beating independently. You give atropine, nothing. Do you repeat it? No. In a complete heart block, the problem is below the AV node, where atropine cannot reach, so repeating it only burns time. Go straight to transcutaneous pacing and sedate. What changed was not the rate. It was where the block sits. One more, a different patient, a marathon runner, resting heart rate of 44. The monitor shows a sinus bradycardia. But she is wide awake, comfortable, with a normal blood pressure and no complaints. Do you give atropine? No, this is an asymptomatic bradycardia, and in a trained athlete a slow rate can be perfectly normal. There is nothing to treat. You monitor, and you look for any cause. Treat the patient, and this patient is fine. One last patient. A slow rate of 36, hypotensive and drowsy, and the chart shows he takes a beta blocker and took an extra dose by mistake. Atropine barely helps. What now? This is a beta blocker overdose, and the specific antidote is glucagon, which bypasses the blocked receptors to speed the heart. So you pace and support as always, but you also reach for glucagon, because here there is a cause you can directly reverse. Always ask what slowed the heart in the first place. Next episode. Sudden, severe shortness of breath. You listen, and on one side, there are no breath sounds at all. The trachea is shoved toward the other side, the neck veins are bulging, and the blood pressure is falling. Air is trapped under pressure, crushing the lung and the great vessels. There is one needle, one location, and no time to wait for the X-ray. Where does it go? That is episode 13.